No, nice. And so it's great to see some folks out. I think I know most of the people in the room. My name's Andrew Reeves. I'm a professor of political science and the director of the Weidenbaum Center. I'm sure you all know a little bit about the Weidenbaum Center, where I presently stand. This is the physical space. We're a research institute here at WashU that we do a lot of work. We spend a lot of money funding faculty research. We're nonpartisan, we're non-advocacy, but we do a lot of work in spaces where public policy really is an important part of what we do. I lose the function to speak around 3 o'clock, so I'm heading in that direction. So the other thing that we do is we put on programming like this. We have conversations about really difficult, important, pressing issues in a space where we support the points that we're making with research, and we get to talk to leading scholars in those fields to provide information for us. And so today we're really honored to hear from Liz Chiarello from SLU, who is an associate professor of sociology. And moderating our discussion today will be our associate director, Elizabeth Larson, who I will both introduce. So I'll start by introducing Elizabeth Larson. Elizabeth Pippert Larson is the associate director of research and administration at the Weidenbaum Center. She plays a vital role. We're a small but mighty team. Me, Elizabeth and Alana and Kristen. And so Elizabeth plays a vital role in managing the center's research program. She oversees budgets, engages with our sponsors. She does a lot to support faculty in securing both external and internal grants. She supervises staff, helps organize public events like these, handles fundraising, donor relations, and all sorts of other things. Immediately prior to joining us here at WashU, she was a consultant for the U.S. Chamber of Commerce and the Business Roundtable. Elizabeth is an attorney and is a member of both the Missouri and Washington, D.C. Bar Associations. She also serves on the Community Advisory Board for St. Louis NPR, which is our local member station. Elizabeth holds a BA from Boston College and earned her JD along with a dual master's degree in journalism and human development and family studies from the University of Missouri. She lives in Fox Park in the city of St. Louis with her husband and their 5 children. So thank you, Elizabeth, for moderating our conversation today. Next, I'll introduce Liz Chiarello. Liz is an associate professor of sociology at St. Louis University. She's a medical sociologist and socio-legal scholar. She conducts her research at the intersection of healthcare and law. Her research centers on how cultural forces such as law, politics, and organizational policy influence decision-making in healthcare and the criminal legal system. It's interesting, just in the conversations that we've been having, amongst ourselves, these things all touch us. When we go to the doctors and we think about the medications we need and what our doctors will and won't prescribe. Her current project centers on the U.S. overdose crisis. She examines how the fields of healthcare and criminal justice have used shared surveillance technology to address the crisis and how doing so has changed professional work and undermined patient care. Her research is supported by a National Science Foundation Career Award. Man, that is a really big deal, especially for a social science researcher to receive that. Her book, Policing Patients, Treatment and Surveillance on the Frontlines of the Opioid Crisis, was published in 2024 with Princeton University Press. Professor Chiarello has been a postdoctoral fellow at Princeton University and a Radcliffe Fellow at Harvard University. Her work has appeared in top sociology and socio-legal journals such as the American Sociological Review, Social Science and Medicine, and Law and Social Inquiry, as well as popular media. If you're tuning in to St. Louis on the Air, the New York Times, USA Today, Bloomberg News, Liz's research and her commentary has all been featured there. So please join me in welcoming Liz and Elizabeth in their conversation of Liz's great new book today.
Thank you, Andrew. Okay, all right. I normally would not use the mic, but I'm not feeling 100%, so we're gonna use the mic today. So Liz, thank you for being here. It's an honor, and I've loved reading your book that I was telling you. It's fascinating, and it's great to talk about it. So before we get started on my questions, I'm gonna ask Liz a few questions, and then we'll open it up if you guys have any. And the book is for sale out there with Left Bank. So Liz's book delves, as Andrew said, into one of the most urgent public health crises of our time, as we've been chatting about before this began, the opioid epidemic. And this crisis, as most of us are aware or learn from our doctors, has claimed over 1 million lives in the United States. And it's just left a devastating impact on individuals and families and communities. And so as policymakers and legislatures and courts have responded, their strategies rely on technological tools that are embedding surveillance into the heart of the medical practice. And so Liz's book, Policing Patients, brings us to the front line of this epidemic, where doctors and pharmacists are facing decisions about whether to dispense medications that can alleviate pain, but also fuel addiction, or can fuel addiction. So through in-depth interviews with with physicians and pharmacists and law enforcement agents, Liz provides a vivid account of how these professionals are navigating the tension between treating patients, but also are policing them. And so one of the singular ways that patients are policed is through the Prescription Drug Monitoring Program, or PDMPs. So PDMPs are databases that are powerful tools capable of tracking controlled substances within and across state lines. But these databases blur boundaries between healthcare and criminal justice. It can erode trust, and it complicates the relationship between patients and providers. And so your research really sheds light on how these surveillance systems are designed to help people, but also have far-reaching consequences, forcing professionals to weigh their role as caregivers against state mandates, and also what you call a zero-sum game between pain management and addiction treatment. So today we're going to talk about unpacking all these complexities and how we can reframe the conversation around opioids, and possibly talk about some policies that prioritize treatment and prevention, and even harm reduction. So I guess the first question is, this book is about policing patients. Literally, that is the title of the book, but it's also a book responding to the opioid crisis and the responses to the crisis. And you say our perception of what triggered the crisis is wrong. It wasn't just Purdue Pharma, or just in some cases greedy doctors that hooked a generation onto drugs. So can you talk a bit about the cause, the actual causes?
Absolutely. Well, let me say thank you, of course, to Andrew for this very kind introduction, and to the Weidenbaum Center for hosting me, and Elizabeth for being my interlocutor, and all of you for coming. I'm really delighted to be here and to be part of this conversation. So when I think about the opioid crisis, I think about the danger of a single story. Those of you who are familiar with Chimamanda Ngozi Adichie's TED Talk know about this idea of the danger of a single story. And what she says is that a single story is not wrong so much as it's incomplete. And when we tell incomplete stories, we arrive at incomplete solutions. And I think that is clearly what's happened with the opioid crisis. So the story that we all know, that we've heard 1 million times, is the story of an evil drug company, Purdue Pharma, who came in, peddled an addictive medication to doctors and hooked a nation, and caused over 1 million overdose deaths. And that is a very nicely packaged story. But it doesn't honor the complexities of what's been happening for the last 100 years as we've been dealing with opioids in different kinds of contexts. And so I argue that we need to look more closely at the 100-year story and also put this 20-year story into context. And I think the biggest piece of that is the Purdue story is a supply side story. It says the reason people get hooked on drugs is because drugs are available. But drugs are available and a lot of people are not hooked on them. So obviously there's more to that story. And the other side is the demand side. We need to ask, why are people interested in using drugs? What's drawing people in? And that helps answer our question. It's not just that our drugs are available. And so many of our resources are devoted to, for example, stopping drugs from crossing the border, as if by making drugs unavailable, people will not have a drug problem. And I don't know about you, I don't know if we were the same age, but I will tell you that when I was growing up, people snorted the gas that's in the bottom of whipped cream bottles. So people will find a way to use drugs. They don't have to be as readily available as something like OxyContin was. And so I really think we have to put these stories into perspective, and certainly into historical perspective, and also into social and cultural perspective, to understand more than just the economic story of a hungry drug company doing a lot of harm.
And then, however, there were some doctors, I guess, that were maybe greedy or not professionally responsible. Is that fair to say?
You're being very generous.
And so, yes, so I told you that there's one example that my kids found pretty interesting about a doctor that, well, maybe you should tell the anecdote about the x-ray with the dog, but what were some other examples of some greedy doctors in your research that you found that were stark examples?
Yeah, so I think I should probably tell you who I talked to. I did 337 interviews with physicians, pharmacists, and enforcement agents, largely in California, Florida, and Missouri. And I picked those states because Florida was really a hotbed of activity as far as the crisis was concerned. And a lot of people were really focused on Appalachia, but I was interested in how organizations with resources were dealing with the crisis. And so going to an under-resourced space didn't make sense. So I went to Florida, California, and then Missouri, based on where the prescription drug monitoring program, which we'll talk about in a minute, is located. But as far as law enforcement is concerned, I talked to everybody: local cops, DEA, Board of Pharmacy investigators, Board of Medicine investigators, fraud investigators at the state and local level, defense attorneys, prosecutors, U.S. attorneys, board members, you name it, I've talked to them. And so the story that you like is this story about the dog x-ray. So some of the investigators that I talked to, they were going after this doctor, and they needed to prove that he was prescribing these opioids non-medically. And so they brought in an x-ray of a dog, and it's obviously a dog. Even those of us with no medical training at all can look at this x-ray and say, that's a dog.
The tail.
You can see the tail.
Yeah.
That is the clearest clue. So they brought it to this doctor, and the doctor was like, oh yes, I can really see why you're having so much back pain, and then went on to prescribe an absurd amount of opioids. So this was in Southern California. I traveled to Florida and I talked to this DEA agent. They had heard about the dog x-ray in Florida. The story had made it all the way across the country. And she was like, you know what? I just took my cat in to get some blood work. And so she took the cat's MRI. It wasn't the blood work, it was the MRI. She took the cat's blood, why am I obsessed with blood right now? She took the MRI, she changed the cat's name was like Mittens. So she got rid of Mittens, she put a human name, but it still said feline. And took that to this doctor in Florida, and that doctor prescribed his standard, which was like OxyContin and a couple of other opioids, and I think a muscle relaxant. And so these are some of the strategies that they used. But there were doctors trading drugs for sex. There were doctors who were selling pills out of their trunks. There were doctors who had pills in the ceiling of their office. I've seen videos of doctors saying, oh, I really shouldn't give give this to you, but I'm going to anyway. And so there are some really egregious examples. And law enforcement likes to say that they go after the worst of the worst. And these are some examples of the worst of the worst. But doctors who are practicing in daily practice, all they know is that law enforcement is going after doctors just like them who provide pills just like them. And so even if law enforcement were going after the worst, other doctors still are afraid. And so there is still a chilling effect across the profession, even if law enforcement was really going after a very narrow scope of positions, which we don't know is exactly true.
Yeah. So can you talk a little bit now about the prescription drug monitoring program and because this gets at the heart of the book, like what is it, like what are PDMPs, like how does it work? Kind of walk us through that and then how it changed doctors' jobs and then maybe pharmacists and law enforcement.
Sure. Raise your hand if you've ever heard of the prescription drug monitoring program. Most of you. Okay, this is, you have now. This is more than, yes. Good, I've spread the word. This is more than in most rooms. Most people have never heard of these programs, although many of us are being surveilled by them. So prescription drug monitoring programs are surveillance systems that were designed for law enforcement, but over the last 20 years or so have been integrated into the healthcare system. And so the way they work is if you take a controlled substance, which is, it's a variety of different drugs that are scheduled by the DEA as C1 through C5, with C1 being the most dangerous, according to the DEA. Marijuana is a C1, so I want you to think about how categories are constructed, but this is the way it's laid out. C1s are like marijuana and heroin, C2s are Oxycontin, C3 traditionally was Vicodin, C5s are some other kinds of painkillers, but things like benzodiazepines that are used for anxiety are controlled substances. So is testosterone that's used for gender affirming care. These things are all in the database. So when you go to pick up your prescription at the pharmacy, the pharmacist sends that information to whichever part of the state runs the prescription drug monitoring program. Sometimes it's the Department of Justice or the Board of Pharmacy, Consumer Affairs. This is where they're housed. But they are in a public-private partnership with an organization that's called Bamboo Health. And Bamboo aggregates all of the pharmacy data and then feeds it back to physicians and to pharmacists who can use it to make decisions about patient care. But they feed the same data to law enforcement who can use that information to go after healthcare providers. This is individual patient level identifiable data that is not covered by HIPAA. It does not have the privacy protections of your electronic health record, for example. I talk in the book about these technologies as Trojan horse technologies. And the reason I call them that is if you think back to the myth of the Trojan horse, the Trojans were horse people, like it was kind of their thing. And so that's why the Trojan horse was such a perfect gift for them. But what they didn't anticipate when they wheeled this enormous horse behind their walls was that hiding inside were Greeks who wanted to kill them, and kill them they did, and brought an end to the Trojan civilization. The PDMP works exactly the same way. Not exactly, but similar. The PDMP was built for law enforcement. It's used in the interest of law enforcement, but it has been placed in healthcare. And what healthcare providers and healthcare leaders don't realize is that embedded in this technology are enforcement logics that emerge over time as we see healthcare providers use these technologies in the day-to-day. And so you were asking what actually happens to doctors and what actually happens to pharmacists. Okay.
And are they required? Like, is this something that pharmacists are required to do?
That is a tricky question. So historically, no. Historically, it was optional. But over time, especially as we've seen these huge lawsuits against Walgreens and CVS and Purdue, more and more states are starting to require the PDMP, but also more organizations are starting to require the PDMP. So Walgreens, for example, was sued in 2009. This was before all of these big lawsuits came out. And after that, they created what they called a good faith dispensing program that required pharmacists to call physicians and ask them all these questions and make sure that the medication was appropriate. And doctors hated it and pushed back against it, but that kind of thing is still in place. But at a practical level, in terms of the day-to-day interaction between healthcare providers and patients, doctors use PDMPs alongside other kinds of enforcement technologies. So most commonly, well, actually, I should say legally, physicians are only allowed to provide opioids for pain. But the patients who come in might be using them to treat pain. They might be using them because they have a substance use disorder and they're trying to avoid withdrawal, or they might be diverting them. They might be selling those medications. The same patient could fall into all three of those categories or into multiple categories. But legally, doctors can only prescribe them for pain. So doctors have a really hard time figuring out which patients are in pain and which patients fall into these other categories. And so the PDMP really helps them with that. The way doctors have set things up recently is they require patients to sign a pain contract that says things like, I'm your only doctor. You're only going to go to this one pharmacy. You're never going to go to the emergency department to try to get medications. I am going to test your urine when I want to. Some of them say, I'm going to do random pill counts. And what that means is I can call you up or text you and say, you have to show up at my office within 24 or 48 hours. I'm going to count the number of pills that are remaining in your pill bottle to make sure that you're taking them appropriately. I see your look, Molly. I feel that way too. Like imagine that with any other medication. Imagine your blood pressure medication, or your heart medication. Imagine your doctor saying, you have to show up at my office within 48 hours because I'm going to count the number of pills in your bottle. But we're doing that for opioids. So pain is incompletely medicalized. It's basically on the cusp of medicine and criminal justice. So, and then the PDMP is basically a lie detector test. They're asking the patient questions, but then they look them up in the prescription drug monitoring program and they can see all the other doctors you've gone to, if you've ever gone to the emergency department, what other opioids and other kinds of medications you're taking. And any violation of that pain contract can either mean you get tapered down off of your opioids, which can send you into withdrawal, or it can mean you getting dismissed from the practice. And then that leaves these patients with nowhere to go. As far as pharmacists are concerned, pharmacists, of course, are stuck in this really tricky medical hierarchy where doctors are on top and everybody else is on the bottom. And doctors do not have, pharmacists don't have access to much medical information beyond what the patient shares with them. They don't even have your diagnosis. They just have your prescription. And so the PDMP really helps them make decisions because they are also legally obligated. The same law that requires physicians to prescribe in good faith requires pharmacists to have a corresponding responsibility to make sure that medications are being used for medical purposes. And so before they really had no way to do that, but now they look patients up in the PDMP, and that makes things much easier for them. Again, they can see what patients are taking, and then they use that to make decisions about whether or not they're going to dispense. And you might be thinking pharmacists can decide not to dispense things. In fact, they can. They practice under their own licenses, and so they have right of refusal.
I think that was one of the things I found the most interesting, was how you started this. I didn't know anything about that with the pharmacists and how you started this mainly around reproductive justice and the abortion pill and how varied that is in states. And anyway, how sorry to divert a little bit from opioids to abortion, but so what got you reaching out to pharmacists on the opioids? Can you tell that story a little bit from how you initially started reaching out to them?
Absolutely. As a researcher who cares about presentation of self, I would love to tell you that I started this project because I knew that the opioid crisis was an issue, and I made a perfect research design, and I went out and I studied opioids and I wrote a book, but that is not what happened. What actually happened was I started graduate school really interested in reproductive health and reproductive justice. At the time, pharmacists were making headlines because they were refusing to dispense emergency contraception, which is the morning after pill. It's not the abortion pill. It's not RU486. It is, it's something you can take within 3 days of unprotected sex. And pharmacists were refusing to provide it because they believed that it was an abortifacient. And I was really fascinated by that. I thought, here are healthcare professionals who are obligated to know the science and act on the science, but they also have their own individual moral beliefs. And so how are they grappling with those competing ideas as they're making decisions in their practice? So then I did a really beautiful research design. I had 4 different states with different laws. I did a more conservative and a more liberal county. And then I did Catholic and non-Catholic hospitals. And I did a variety of chain pharmacies across all of those states, the same chains. So I went in, ready to talk about reproductive health. And the first question that I asked pharmacists was, what would you say are the key ethical issues that pharmacists face in daily practice? And I knew that they were going to say emergency contraception. And across the board, they said opioids. And this was 2008, 2009. So this was before the opioid crisis was really on the national radar. And so I ended up with all of this data about how they were making decisions about providing opioids in addition to the emergency contraception questions. And so that just took me off into a whole new direction. And so I thought, okay, I know what's happening with pharmacists, what's happening with physicians, and law enforcement's also involved. Law enforcement and healthcare providers were holding these conferences together, and police chiefs were saying things like, we can't arrest our way out of this problem. And I was like, these are really different fields with different people and different ways of solving problems. And here they are wanting to hold hands and work together to solve a problem. I thought that was really fascinating. And so then I really dove into this work.
Yeah. So of those 3 groups that you talk about of the surveillance, the pharmacists, the physicians, and law enforcement, what was the hardest group that didn't want to talk to you?
Oh, that's a great question. So pharmacists are actually, they were
They
very
seemed open,
receptive.
yeah.
They were really receptive, and pharmacists have the fewest barriers of any healthcare providers. You can literally walk up to the counter and talk to a pharmacist within 5 minutes. You can't do that with a physician. I thought law enforcement was going to be the hardest. I started this project and I was like, maybe someday I'll talk to someone in the DEA, right? And actually, once I kind of got there through networks, but then once I got in with the DEA, they then introduced me to everybody they knew across the country. And so they were actually pretty easy once I got in. Doctors were really, really hard. They're hard to get to anyway. But then once I got to, I remember one woman wanted me to pay her for participation. And I was like, I can't do that. But then once I talked to them, they had some really interesting things to say. One woman, it was Florida. Florida was the hardest.
Yeah.
And I think it is because they were such a hotbed. Like everybody had been talking to them and they were sick of it. And they were blamed for the opioid crisis and they didn't want to deal with it. But this one woman, I had just gone to her office and dropped off my card and asked her to call me. And then I saw her in the elevator and I recognized her from the internet. And so I was like, this is, this is a little awkward, but would you be willing to talk with me? And she was. And so then I came back later and had a conversation with her, which was great. But yeah, the doctors were they don't have a lot of time. They don't really want to talk about it. Everybody wants to talk to them. And so
Yeah.
I think the pharmacists feel a little bit lucky to be researched because nobody pays attention to them. But doctors, everybody's interested in talking to, and so they were much harder.
Going back a little bit, you talked about the metaphor analogy that you use a lot, the Trojan horse. And so what is the answer to that? I mean, it's here, the surveillance is happening, PDMP's likely here to stay. I don't see that going away. So what should we, as citizens, what should our response be? And however you want to take that, what should pharmacists be as compliant? Is there an answer politically? Is there an answer legislatively, or should, however you want to take that question?
Yeah, I think there are a lot of answers, and you're right. I mean, it's we've implemented the system, the likelihood, and then we have shrouded it in language about patient safety.
Mhm.
And it's going to be really hard to undo that, to take that away. But there are issues of privacy that I think really matter here, particularly because the medications that are in the PDMP are controlled substances. And you might think to yourself, well, I don't take an opioid or a benzodiazepine, so I don't care if I'm being tracked in this system. I'm not doing anything wrong. But the thing is that those schedules can change. So going back to reproductive health, Louisiana just scheduled mifepristone and misoprostol, which are the two drugs used in medication abortion. So those will go into the PDMP in that state. And so even if your drugs are not being tracked now, you might think about what drugs might be tracked down the line. And PDMPs are not like your credit score. You don't get to see everything that's in them and then make corrections to them. And increasingly, they're algorithmically sophisticated and they create a risk score. We don't know what goes into that risk score. And so that's all shaping how providers make decisions, is this black box algorithm that's owned by a corporation. And that's shaping a lot of decisions in social services, in healthcare, and in law enforcement. And so I think we need to really push to make sure technology is being used in the public interest.
Yeah.
It's not just about protecting our individual privacy. It's about making sure tech works for us and not against us.
Mhm.
And this is a case where the technology exists. The biggest challenge, I don't think, is that doctors and pharmacists have access to it, but rather that law enforcement gets access to your individual patient data, and how they're interpreting the provider data. And so even though they have given us this lovely gift, it might be time to create some stronger boundaries between healthcare and law enforcement so that these boundaries are not blurred so easily through the use of this technology. The information is really helpful. Doctors and pharmacists should know who else you're seeing, what else you're
Yeah.
taking. But law enforcement doesn't necessarily need that information. And so integrating it into the electronic health record, where it's actually protected by HIPAA, I think could go a
Yes.
long way towards making PDMP data helpful.
Yes, I was horrified to know that Tom, my pharmacist, was sending my data to law enforcement, like just by proxy of him just sending it off every month or week or whatever it is that my pharmacist does.
Yeah.
So as I think you all know, the Weidenbaum Center is one of our client departments is sociology. You are a sociologist. Talk to us about how sociology can help us with this problem and what your field can help us do as we look at both the data and the technology and the law enforcement piece of all this.
So I was not,
And the
okay.
drug crisis too. Like, I do want to add that that is like a very real part of this conversation as well.
Yes, absolutely. So, I do not have a bachelor's degree in sociology. Both my bachelor's and my master's are in psychology. And then I shifted to sociology when I started my PhD. And so I have, the fervor of a convert. Like, I really love sociology. And I think it has such great perspectives on things and so much useful theory. And that is what I think sociology really brings to the table that some other disciplines don't. So most of the books about the opioid crisis that you're probably familiar with are usually written by journalists or they're written by doctors, and they have important perspectives to share. But sociologists have bring theory to the equation. And so we're not just thinking about opioids and this single crisis, but we're also thinking about black box algorithms and how they're being implemented in a variety of other places. We're thinking about the ways that the fields of healthcare and criminal justice are becoming blurred. What are the mechanisms by which that's happening? We are thinking about the criminalization of care.
Mhm.
So we're thinking about efficiency norms and how those are changing a number of different professions. And so all of that, I think, are things that sociology brings to the table.
Yeah.
But sociology also helps us think historically. You know, I told you this is rooted in 100 years of a drug crisis where the pendulum has been swinging between the medicalization and the criminalization of opioids. So we can see that sociology looks at a micro level. We can think about the interactions between a single doctor and a single patient, but we can also think about the whole field of medicine and how it's engaging with the whole field of criminal justice. And so I think because sociology helps us think about culture and organizations and politics and practice, it gives us a very holistic and theoretical understanding of the problem, and of solutions.
Can you talk, so I do want to leave some time for questions for you all, but do you want to talk about some of the solutions that you outline?
Yes, and I will just talk about those very briefly. I argue that we need a three-pronged approach to solving the opioid crisis. What we're doing right now absolutely is not working. We're losing more people every single year, and so we have to stop. And our main strategies right now, like I said, are these supply side strategies. So we want to stop the drugs from getting into people's hands. And that certainly has a place. But we also need to think more about demand. And the other thing that we tend to do is we think that abstinence is the only way, is the only mechanism of recovery. And I think that that is far too narrow, and it creates too high of a bar for people who are just trying to improve their lives. And so the three-pronged solution is grounded in harm reduction, treatment, and prevention. Harm reduction has a very basic philosophy. The idea is you meet people where they're at and encourage any positive change. So it's not abstinence, it's not you have to get off every drug immediately, but it's, you were using every single day and now you're using every other day, or you were using with the same syringe and now you're getting yourself sterile syringes. That is a positive change and we want to encourage that. So harm reduction includes things like syringe service programs that provide clean needles for people who inject drugs. You can prevent the spread of all kinds of infectious diseases that way. Overdose prevention sites like the one in New York, where people use drugs. They don't give them the drugs, but they use drugs among healthcare providers and people grounded in harm reduction. Narcan, naloxone is a good example of harm reduction. And so I think harm reduction is incredibly critical to solving this problem. The second is treatment. So when you think about treatment, you probably think about 28-day inpatient treatment, which works for some people. It works for about 10% of people. It's also a risk because when people are in those kinds of programs, their tolerance goes down. And addiction is a chronic relapsing disease. And so people use again, and then when they use again, they often overdose and sometimes die. And so we have to be careful about treatments that can do worse than fail. The most effective treatments for opioid use disorder are methadone and buprenorphine. Methadone is kind of held captive in opioid treatment programs where people have to stand in line every morning to get access to their medication. Again, I want you to think about that. If you take an antidepressant, imagine having to go to your doctor's office every single day at 7 in the morning and stand in line to get your antidepressant. That doesn't work well, and it doesn't work well for methadone either. We need to put methadone in pharmacies, and we need to encourage physicians to prescribe it. And in fact, we could get pharmacists to provide it through collaborative practice agreements with doctors. So there are a lot of ways to make this really fantastic, inexpensive, effective drug more readily available. Buprenorphine is newer, it's still on patent, it's more expensive, but it is similarly effective. We need to push to make that medication more available as well. And we need to right size pain treatment. We had a moment where everybody got an opioid. Well, not everybody. There were still race and class and gender disparities, but a lot of people got opioids to treat a lot of different things. And now we're in a moment where almost nobody can get opioids, even for things like surgery. It's really, the pendulum has really swung back. So we need to right size pain treatment. Some people need opioids. They work well for some people in some conditions. And so we need to find that sweet spot. And then the third part is prevention. And by prevention, I don't mean like cops in schools in the DARE program. I mean capital P prevention, which means dealing with some of the thorniest social problems in our society. We need to make sure that people have housing and employment, are free from violence, that mental health disorders are treated. And I know that sounds like I'm saying, let's do everything all at once, but let's do everything all at once, because otherwise we're just trapped in this cycle of crisis after crisis after crisis and social problem after social problem. We have to treat these things as if they're connected because they are, and actually do the work we need to do to make our communities as healthy as possible. Thank you. You're welcome. Thank you.
I would love to take some questions. We have a little bit of time and then wine after. So yeah. So if anybody has any questions, please just feel free.
And we have a mic, right?
We do. Yeah. Elena, do you mind?
Yeah.
Sorry, let me just turn it on.
Maybe you can just identify yourself.
Yeah, that'd be
Yeah,
great.
yes.
Yes, please. Thank you, Andrew.
doing some research. Curious about, you mentioned pharmacists. Did you also talk to distributors like AmerisourceBergen or Pfizer?
I did not, and in fact, I didn't talk to patients for this project either. It was law enforcement physicians and pharmacists. What are you thinking about the distributors?
Well, in our research, what we are looking at is, are you aware of the ARCOS database? That's what we have been working with. That was made publicly available by court order. So
Oh, I didn't know it was
that
available.
tracks the movement of pain pills over a 7-year period, actually.
Mm.
Washington Post made that available. So we are looking at ridiculously large shipments going from distributors to specific retailers or practitioners around the country, and then being able to flag them as suspicious. So we are using sufficient analytics to do that. So since they coughed up really huge settlements, and the largest settlements were like that with the distributors more than anybody else.
Mhm.
So how comes you did not touch that part of the supply chain? Was that not something that you wanted to look at?
Well, I am a sole researcher who, over 10 years did over 300 interviews. And so I could not add anything. I really wanted to talk to patients too, which I'm doing for the next project, but I simply had to stop. At some point, you have to stop. And so I did. The distributors are interesting and important, I think, and because my questions were really about healthcare practice. I wanted to understand how people were making decisions and how the environment in which they were practicing had changed over time. And so I really capture that question with the research design that I used. The way that the distributors really matter now is that there are shortages of opioids, of buprenorphine. A lot of pharmacies don't carry them because they're concerned about the risk. And so patients are having a really hard time getting access to care. For example, patients on opioids for chronic pain might be on very high morphine milligram equivalents, so really high doses. And the pharmacy doesn't have enough to fill it for them. And so then they end up going from pharmacy to pharmacy to pharmacy trying to find the medication. And so getting that balance right between how much is distributed and how much patients can access, I think is really critical. And so on the one hand, you do want to flag problematic distributors and where it's going. On the other hand, you want to make sure that it doesn't negatively affect patient care. So I think that's all part of the same string. Did you have a question? Yeah.
Yes. I went to a stock investment conference, and one of the companies there was called Nutraband, and they have a transdermal patch that contains for fentanyl that cannot, they say people cannot get the fentanyl out of it. It's designed not to. And I didn't know if they're hoping that this would be one of the solutions, even that the government might require this the only way you can have a transdermal patch so that people can't abuse it or take the fentanyl out of it. I wonder if you've heard of it, and I don't know how many are pills and how many are transdermal patches, and whether you think this would make a difference or not.
This is a really great question. So first of all, I think we have to differentiate between the fentanyl that most people are overdosing on, which is a legal fentanyl, and prescription fentanyl, like the type that you're talking about. So the way, unlike Oxycontin, which people were chewing up and snorting, it is really hard to use the transdermal patch, to misuse the transdermal patch. The biggest challenge with fentanyl is largely the liquid form that they use in hospitals, where and a lot of times it's hospital staff who will divert that fentanyl. There is a horrifying podcast that is worth listening to, The Retrieval.
Yes.
I think if you've heard it, you're cringing a little
Yeah.
bit right now just thinking about it. It's a story of a nurse who was diverting fentanyl from women who were getting IVF. And so they were having their eggs removed with no pain medication. It was the Yale fertility clinic, and it is a horrifying story. But I am always really skeptical about the idea that this is the only way that we can provide a medication. Because of course, corporations are interested in making money, they're interested in having their medication on patent, and they're interested in having exclusive market share. And so for me, I want us to think about what's best for the patient. And so for some patients, the patch is the best thing. For other patients, pills are better. But fentanyl generally is not prescribed in the outpatient setting. It is a little bit, but not like some of these other medications like OxyContin. And so using a patch in the hospital doesn't seem problematic to me, but I think you have a lot more control with a liquid than you do with a patch. And so I want someone more versed in the mechanism of action to look at that. But yes, I think there are probably multiple parts to that story. Yes.
So interesting enough, I'm a ago. And one of the questions they ask, every time you go to the hospital is, do you have access to weapons? Do you have, basically, and people find this.
Yeah.
And a new question is, do you have access to excessive amounts of pills? And, things that could kill you. And so I said, well, yes. And she said, well, why? Because she sent them to me. They sent, they might be told her, I'm getting 600 milligrams of something. And it's gonna be a giant container, and all I have to do is go on my app and click on one refill. No one's calling me to say, did you go through the other 900 already? And so of course the answer is yes, I have them. And how do I get rid of them? Right, so that's the other thing is, what do you want me to do with them? I've got them from 2002, sitting in my house. What do you want? So we're just sitting there in the back of my closet, just, I don't know, deteriorating, I guess.
Yeah.
So the interesting, no, and they know, we have this conversation with them all the time. But I found it interesting that, and so for me, I'm always like, where's the money here? So I'm always about, all the money, why is it so, there's gotta be some money in this space that pushes all of these pills to me. Did you find any information about was there anything that bubbled up to the surface about how much it's costing? And then the last piece of that is, I appreciate you mentioning that not everyone gets that. There are definitely disparities. And so then my other question is, particularly in the Black community and some Black and brown communities, the conversation I get from my friends are, oh, now it's a problem. It's been a problem in this community for a long time, but now since some cute, rural white kids in trouble, now suddenly it's a problem. So did you find any of that kind of stuff?
So I'll start with that question first. In terms of race and gender inequality and access to opioids, in that very liberalizing moment where kind of opioids were available for all kinds of things, it was still the case that Black people and women and Black women, Black men, white women, and Black women were not getting access to medications. They were getting less powerful opioids with fewer refills in lower doses, exactly. And so that was always the case. There were some economists, like maybe a year or two ago, who speculated that actually that was a protective factor because it meant that they were not getting addicted to pills. And there's been a huge pushback, right? So your pain wasn't treated, but at least you didn't have an addiction problem, right? And so there's a lot to unpack there. There is a great book about this. It's called Whiteout, written by Helena Hansen, who is an anthropologist, and Jules Netherland, who's a sociologist and a historian. That is a really good place to look for a really nice explanation of the racial disparities in access to care. And it's so interesting you talk about being a veteran. I think a lot about deservingness and the social construction of deservingness. I write about it a little bit in the book. And so, of course, veterans are understood as particularly deserving in terms of access to care. Cancer patients are the other group that are understood as very deserving. And opioids aren't always right for cancer pain, but a lot of cancer patients have huge bottles of pills because they're understood as so worthy. And so yes, I think that's all part of it. In terms of following the money, well, certainly Purdue and these other companies were making money hand over fist. I don't know that I can answer the question about today, why it's still getting pushed out. I think a lot of it is just normative, right? If you have access to 3 months supplies of things that they send to you, it's all part of the system. It has become really institutionalized. And so there's nobody really questioning all of that going out. And certainly the drug companies are making money off of those medications, although it depends on what you're taking, because if it's not on patent, it's super cheap and they're not making a lot of money. Where your pills can go. The DEA does a drug take back day. They do it twice a year. And so if you just keep your eye out for that, that is where you should definitely take the pills that are in the back of your closet from 2002. Those are they no longer even work. You can get rid of them that way. Some pharmacies have takebacks and some police stations have takebacks. So you should be able to look that up online and find them. The other thing you can do is I can picture the thing. I cannot remember the name of the company. You can buy these little baggies that are used to destroy them. You basically pour hot water into them and destroy them. And I think they will send those to you for free. If you have a lot of pills, it's going to take a lot of baggies. So I don't think that's the best option. I would probably take them to a take back day, if at all possible. You just hand them over, no questions asked. What's that? Terra bags? Terra, you're right. Yes, they're black and I can picture them, but yes. And so those are some of the options. But yeah, the financial story is an interesting one, and that's definitely a thread worth following.
Molly, we're reading
I have one, but I'm Molly Klein, and I'm just a member of the Weidenbaum Center here. I am a plant scientist. Involved in the science part. I'm curious in your study, did you get into it all how we produce the opioids, like the source of the actual drug, the ingredients, and is everything imported? Did you uncover anything like some of the US drug companies, and Weidenbaum being one of the largest producers, to try to produce in the US, did you find anything about the policies?
I did not focus on that because I wasn't really looking at, I wasn't looking at the traveling, but it is fascinating from a plant scientist perspective. Let me think about, I know there is a book that talks about it. I think it's David Courtwright who has written about that history that might be worth looking into.
Right, and Mallinckrodt did correct, and they did have successful varieties, but best knowledge I have, they did not ever commercialize. But I was wondering more about the money trail. See, like, why did the US, if they've always sourced it from, Afghanistan and whatever other countries?
Yeah, so I think, the money really comes from the drugs being on patent. And that's why OxyContin, they reformulated OxyContin, I want to say in 2008 or 2009. And they said, oh, it's because people are overdosing, but it's really because their original formulation was going off of patent. And so by changing it, they got to keep on patent. But Mallinckrodt is, I believe, the biggest producer of opioids, perhaps in the country.
Yes.
It's one of the biggest in the country.
Which is not, I don't think a lot of people know that.
They don't, and they produce all the generics. And so, yeah, they are pretty critical in terms of the drug, I wanted to say the drug trade. That's not what I mean. The economy of drugs in the US.
In terms of the holistic approach, what about going back to what is pain? And, even the concept of aging, and if you just took all the skeletal problems that people have as an example with aging, have you found anybody trying to get back to that concept of prevention or better health, just so people don't have pain, especially pain that didn't come from injury, but is just coming from aging or something isn't proper in the body? So just curious.
Yes, I think that's really important. And I think, again, that goes back to institutionalization. So if we think about the difference between mainstream medicine and more holistic medicine, that's where it's in holistic medicine that you see a lot of, a focus on prevention and a lot of focus on health and healing. mainstream medicine has really turned towards treating disease, treating conditions after they've already happened. And so, I mean, my dad's a doctor and, you used to get a checkup every single year, and fewer people are doing that. Insurance covers that. Speaking of economic interest in this whole thing, I think doctors really struggle in terms of treating pain because they're not really trained to treat chronic pain. They're trained to treat acute pain oftentimes, but they often have had either 0 classes in pain or maybe 1 class in pain, and there are a lot of patients who come to them with pain. And so I think looking outside of mainstream medicine is important, but we also need a way to pay for it because there's some really wacky stuff out there, and then there's some stuff that really works, and it can be very hard as an individual to figure out what works and what doesn't.
Hi, my name is Dana Hines. I'm a friend of Liz. On the law enforcement side, how far down the food chain does that PDMP information go? I mean, if you get pulled over, can they say, oh, well, she's taking,
Right now, no. Local cops do not have access to the PDMP. It's the DEA generally who has access, and some sheriff's departments have access too. But they are increasingly folding things in like arrest records into PDMPs. They're making, and so then your doctor might be making decisions about providing you medications based on your arrest record, which is, again, it's that blurring boundaries between healthcare and law enforcement.
I actually had one just going off of that, and I also wanted to say such an impressive amount of evidence that you have. I know you probably could have published the book with like 100 interviews, right? So I think people should know, like, that's a crazy amount of interviews. I wanted to, build off of that, ask about kind of like the human networks involved in some of this Trojan horse story. So like, not just the data being accessible between law enforcement and healthcare, but, to the extent that there's now brokers or avenues for communication between these two institutions, like that also seems to be pretty significant. So I wonder, just anecdotally, if in people's interviews, things came up about like, oh, now I have someone I can talk to, or, I have, people over there I can reach out to.
That is a great question. I do talk about this in the book. The network that surprised me most was the relationship between pharmacists and law enforcement. So some pharmacists told me about DEA agents who came into their pharmacy and gave them their card and said, call me anytime you need me. But the most surprising one for me was his name was Min, not his real name, but he is a pharmacist in Kansas City. And he told me about a patient who was passing fraudulent prescriptions. And so he had called law enforcement, and law enforcement said, let me know when she's coming and we'll come and arrest her. So he put candy in her pill bottle and then called the police, and the police came and arrested her. So I heard a lot of this from both pharmacists and from law enforcement. Law enforcement said pharmacists are some of our best informants for both doctors and patients. And then pharmacists got much more comfortable calling law enforcement once they had the PDMP, because then they felt like they had hard evidence about what their patients were doing. Even though PDMPs are not perfect and don't have perfect information, they felt like they had something to go off of. So it has strengthened that network between law enforcement and pharmacy in a way that I think we should all be a little bit alarmed about.
Liz, thank you so much. This has just been so fascinating. And I think we could ask questions all day, but great news, we can do it over wine. So I just wanted to highlight, as Andrew said, we're the Weidenbaum Center. Everybody should have gotten a list of our events. This is our kickoff for this semester, and her book is for sale up in the atrium. Please join us for any of these events. They're all open to the public. And please join me in thanking Liz for a fascinating conversation. Thank you.